Hello, everyone, and welcome to Behind the OR, the Peter Surgical Podcast channel, where we invite experts to reveal to us what's happening behind the closed doors of the operating room. Together, we will explore surgeries and procedures and discover more about a surgeon's life in their daily mission. Take off your gloves, take a breath, and let's talk behind the OR.
Hello everyone, it's Dr. Hassan DEBBAGH, a cardiovascular surgeon here in Morocco. In our previous episode, I had the pleasure to recount the journey that led me to the very idea of a cardiac surgery center. Once in Tangier, it was necessary to analyze and understand the social, cultural, and professional environment to which I would not be confronted, which implies a negative context, but let's rather say in which I would have to evolve. Although I am a pure product of the French hospital system and firmly believe in the utility of public healthcare, my diploma equivalence does not open the doors to Moroccan public hospitals for me. In Morocco, social benefits or prestations are not yet meeting those of a welfare state. Although modeled on the French social security system, the Moroccan healthcare system cannot fully meet its ambitions. The healthcare sector in Morocco is organized as follows. Doctors are overseen by a national medical council, represented by its regional delegations. And in terms of resources, we list 1 bed per 1,000 inhabitants compared to 5.5 beds per 1,000 inhabitants in France. 2/3 of beds are in the public health facilities and 1/3 in private sector. Doctors are equally practicing in the public and private sectors. And a census conducted in 2022 found that there were 7.1 doctors and 9.4 nurses per 10,000 inhabitants, totaling 16.5 healthcare professionals per 10,000 inhabitants, when the WHO minimum requirement for universal health coverage is 44.5 per 10,000 inhabitants. Comparatively, in France, there are 34 doctors and 112 nurses per 10,000 inhabitants, totaling 146 healthcare professionals per 10,000 inhabitants. Mandatory medical insurance, which is called here AMO, is becoming widespread, attempting to merge the social benefits that affiliates of liberal professions and civil servants funds enjoyed. It also increasingly covers people who cannot afford to contribute. Chronic diseases and long-term conditions are almost fully covered. Cardiac surgery may be the best reimbursed specialty. Depending on the affiliation regime, patients are covered up to 90 and even 100%, which is a real advantage given the cost of care. Once these data are understood, it quickly becomes apparent that the healthcare environment is not the same, being under-resourced in material and human resources. If we now focus on the specific concept of the heart team, it is essential to define the actors who will take part in the patient's care pathway. Chronologically, in the disease history, the cardiologists, surgeons, anesthesiologists, and intensivists, and paramedical professions. Let's talk about the cardiologists. In 2023, medical cardiology in Morocco was distributed as follows. Nationally, we have 1,132 cardiologists. We count 503 cardiologists in the public sector and 629 cardiologists in the private sector. The national ratio is 30 cardiologists per million inhabitants. For comparison, in France in 2022, 7,400 cardiologists were counted for 68 million inhabitants, which is a ratio of 110 cardiologists per million inhabitants. Compared to other countries, we have a ratio of 142 cardiologists per million inhabitants in the USA, a ratio of 25 cardiologists per million inhabitants in the United Kingdom, and a ratio of 20 cardiologists per million inhabitants in Egypt. If we now focus on the ratio here in the North Moroccan region, we can see that we have 109 cardiologists for 4.5 million inhabitants, which is a ratio of 24 per million inhabitants. Scientific societies exist in all specialties and are very active. Cardiologists lead with national and regional bodies, monthly national meetings, biannual North and South colleges, and several thematic scientific events throughout the year. If we now focus on the cardiovascular surgeons, in 2023, the Moroccan Ministry of Health listed 89 cardiovascular surgeons in the public sector and 42 in the private sector for 38 million inhabitants, which is approximately 3.5 cardiovascular surgeons per million inhabitants in Morocco. However, not all surgeons labeled as cardiovascular necessarily practice cardiac surgery. Some, due to lack of opportunity or training, have turned to vascular surgery. If we compare this ratio to other countries, in France we have a ratio of 7.9 cardiothoracic surgeons per million inhabitants. In the US, we have 11 per million. In the UK, 3.7 per million. In Saudi Arabia, 3.8 per million. And in Egypt, 1.8 per million. In the northern region of Morocco, with 4.5 million inhabitants, there are 3 competent cardiac surgery teams, 2 in the private sector and 1 in the public sector, with the public sector surgeon also practicing privately. These 3 teams involve 6 to 8 surgeons, of whom only 3 are senior surgeons, consultant surgeons. There is no real congenital cardiac surgery activity or only a few rare, simple cases. The Moroccan Society of Cardiovascular Surgery is at agony. No real representation since COVID, a very opaque organization, and almost no scientific events in nearly 5 years. Thematic events are very discreet and mostly organized by patient associations or individual surgeons. What about the cardiovascular anesthetists and intensivists? In 2023, the Moroccan Ministry of Health listed 569 anesthetists in the public sector and 523 in the private sector for 38 million inhabitants, which is a ratio of 28.7 anesthetists resuscitators per million inhabitants. For comparison, in France, this ratio is 176 per million. In the US, this ratio is 200 per million. In the UK, 148 per million. In Saudi Arabia, 41 per million. In Egypt, 50 per million. We can all agree that not all anesthetists, resuscitators have a cardiovascular cap by nature. It's almost parallel to general surgery, just as cardiovascular surgery is a surgical subspecialty. Anesthesia resuscitation in cardiac surgery is also a subspecialty. Perioperative management of cardiovascular patient from preparation to intervention, induction, conducting anesthesia under cardiopulmonary bypass, notably weaning and echographic control of the procedure and restoration of full myocardial function, awakening and post-operative hemodynamic management are all specific skills acquired only within a heart team dedicated to cardiovascular medical surgical care. So what about Morocco? Few anesthesiologists are dedicated to cardiovascular activities, but their training is comparable to European or North American standards. In the northern region of Morocco, the demographics of this subspecialty align with those of surgical teams. Let's get some insights now from another category of workers. The perfusionists are shadow workers. They do not have a recognized professional status. It's an unrecognized profession, albeit with many delegated responsibilities and a high level of risk-taking. The profiles of these technicians remain highly variable, from anesthetist nurses to operating room nurses and more rarely doctors. Access to the profession is challenging. It's a true professional niche. Initial training heavily depends on the goodwill of surgeons and anesthetists. Theoretical training in France, the US and the UK was not strictly mandatory, but is becoming so thanks to the frameworks of established university diplomas and more recently the creation of a specialized master's degrees. Practical training validates theoretical teaching through apprenticeship and a solo operative logbook where the perfusionist in training must validate several adult and pediatric procedures in accredited cardiac surgery centers. Serious game-based tools such as CPP simulators are also available. But what about in Morocco? This skill is rare. There is no real census of this profession. Indeed, the few trained technicians are in the public system and sometimes follow surgeons into the private sector. Although there is a scientific society of perfusion, there is no real corporatism, but significant individualism. This domain remains a protected niche, making it very difficult to train and even harder to be mentored by an experienced perfusionist for whom the trainee is a potential competitor. It is also challenging to keep a perfusionist, since their remuneration is per procedure. Without high-volume activity, they prefer to remain freelancers rather than take a permanent position within a team, posing safety issues. Their availability in case of urgent reoperation or indication is not always granted. What about registered operating room nurses? Operating room nurses in cardiac surgery must have specific instrumentation skills and be able to anticipate and react to vital emergencies, common both during open chest surgeries and perioperatively. Cardiac arrest during anesthesia induction, cannulation complications, post-operative bleeding, etc. Their training ideally stems from general theoretical and practical academic program through a 2-year university curriculum, general surgery, orthopedics, vascular surgery, etc., before specializing in cardiac surgery after a stint in the specialty. Although registered operating room nurses training is well regulated, several pathways allow non-registered nurses with several years of experience to practice in the operating room. What about this skill in Morocco? There are barely any basic nursing training institutes. Most cardiovascular surgery registered operating room nurses often without any basic cardiovascular knowledge, are trained by the surgeons. Once this skill is acquired, some nurses do not hesitate to switch teams to the highest bidder. Just like their surgical counterparts, anesthetists and nurses must be able to respond to situations threatening the patient's life during the perioperative period. Forming a true duo with the anesthetist resuscitator doctor, they must be able to compensate for their possible absence in the operating room. Their training remains very general and they often have a poor understanding of cardiovascular patient hemodynamics, even outside CPP here in Morocco. Several years within a high-volume surgical team are needed to make an anesthetist nurse autonomous and able to manage a patient from anesthesia induction to a CPB weaning. Once we have defined the actors in the heart team, let's see the relations between them. All along the years in the French hospitals, there are a lot of sentences I've heard. Some are funny and some are very, let's say, realistic. The first one is, it is impossible to please everyone. We all agree on this. The second one is, a friend to all is a friend to none. The third one is, we are not here to make friends. And eventually, being nice is not a profession, although it is a skill sometimes. It is well known that certain specialties get along less well with each other than others. The most striking example is the opposition that can exist between interventional cardiologists and cardiac surgeons. This conflict, initially centered on the choice of revascularization strategies for ischemic heart disease, has notably intensified over the past 15 years with the advent of percutaneous treatments of aortic, mitral, and more recently tricuspid valve diseases. Nevertheless, these specialties remain highly complementary and cannot continue without each other, especially with increasingly cross-disciplinary medical surgical profiles. The patient is referred by a cardiologist to a cardiac surgeon based on an indication defined by expert recommendations for management. When followed, this mode of operation avoids diagnostic errors and delays in care in countries with sufficiently developed healthcare systems. Conversely, in countries that do not yet offer an efficient health map, the patient can wander for a long time before their cardiologist proposes surgical management, with pathologies arriving at historic stages that we no longer encounter in Europe or in North America. Several factors are to be lamented: insufficient reimbursement for surgical care and/or poor social coverage, an insufficient number of surgical teams, a lack of surgical skills, let's say it, insufficient perioperative follow-up, and paid clientelism between some cardiologists and some surgeons. Morocco, being a country in the midst of a healthcare revolution, does not escape any of these situations in its current transition. The relationship between cardiovascular surgeons and anesthetists, resuscitators, is quite different. Indeed, unlike a correspondence relationship, it is a tandem relationship. The cardiovascular surgeons cannot perform their operations without comprehensive perioperative management of the patient. The entire surgical management strategy is discussed point by point: medical history and comorbidities, medication management, timing of the procedure, adaptation of the procedure to the patient's condition, and potential complications. Just like a pilot and a co-pilot establish a flight plan before flying the aircraft, no eventuality should be overlooked and solution for each should be anticipated. What about the doctor-patient relationship? The patients here in Morocco have a characteristic that many Mediterranean patients share: closeness. As a doctor, given your highly respected role and status, you now become part of the family. A distance relationship will be nearly impossible. These have disadvantages. Flawless availability is required, and any slip-up may cause the patient to seek another practitioner. Have a dedicated professional phone number. Don't hesitate to courteously insist that you be contacted only by the patient or one of their designated representatives to avoid dilution of information and instruction through multiple interlocutors. The second disadvantage is a greater emotional involvement. Even if required in our relation to our patient, sometimes it is overwhelming. Moreover, without any judgment, it is essential to understand the socio-educational level of the patients and their families. In a country where 30% of the population is still illiterate, and particularly in rural or disadvantaged areas where this figure approaches 60 to 70%, clear, honest, and adapted communication is more than necessary. Many practitioners still use a language that is too medical and/or scientific, rarely accessible to patients and their relatives. This can lead to misunderstandings, errors in following instructions or treatments, and delays in care. So time must be taken at each stage of the care journey, from the first pre-operative consultation to post-operative follow-up, to explain, reassure, and ensure that the information provided is well understood. For prescriptions of additional tests or treatments, do not hesitate to issue them in bilingual versions. For me, it was in French and Arabic, as well as for your operative and hospitalization reports. Even better, record your standard prescriptions and recommendations in audio format to share with your patients. It may seem obvious to repeat, but after observing the behavior of some colleagues who significantly lack patience and clarity, it is up to you to adapt to the patient's level of understanding, not the other way around. After understanding and analyzing the socio-professional environment, the next step will be the casting. Surrounding yourself with the right collaborators remains crucial. It will be my very pleasure to discuss this with you in detail in an upcoming session of Behind the OR. See you!
Let's meet at EX 2024 in Lisbon. on the Booth 230 to discover more about surgery, education, and innovation.